people have joined, or should we wait for some more time? So should we start, Varsha? Please unmute yourself.
Yes, sir.
Okay, so we'll start. There are only 45 people, but still we'll start. Okay, so I am audible and my screen is visible now.
Yes, sir.
Okay. So what we are going to discuss today is basically how to go about reading the X-rays. So we will be dealing predominantly with the X-ray of the chest and few other important X-rays of some bony tissues and all. Uh, so when you go ahead with the X-rays, so this is how you describe an X-ray chest. Okay, first of all, you have to identify. You have to look for the time frame and the indication of the for which X-ray chest was done. You have to look for the age of the patient to the child. You have to look for the orientation. Then you have to look for the technical quality, whether the rotation is fine, expansion is fine, or the penetration is fine. Uh, okay. So these are the few things which you have to look for when you have to describe an X-ray chest. So we will be discussing these one by one. So first of all, identification. So why is identification important? It might not be very important as far as the exam is concerned, but in real life scenarios, identification is very important. Okay, because you may interpret X-ray of a particular person for someone else, and you may do the intervention accordingly. So next is the time frame and indication. So that is also very important. So this is the case history of a 5 years old boy with fever, cough, and respiratory distress for 10 days. He is well now, improving on antibiotics for last 10 days and sitting on the bed, breathing comfortably, and was planned for discharge. So neojubilant SR, who has just finished his MD, saw his X-ray on the rounds. So this was the X-ray. So he said, okay, how can you discharge this child? This X-ray is very bad. You have to put in a chest tube. But then he was corrected by his junior resident, sir, this X-ray is 10 days old. The recent X-ray is this one, this is fine. So that is why do we say when the X-ray was done is important, and you have to interpret it in relation to the patient. So X-ray is not a diagnosis. X-ray again cannot give a diagnosis. So you have to interpret when it was done, for whom it was done, and why it was done. Okay. So the next thing is age. So why age is important? So here you see 3 X-rays. So what is your interpretation? So देखने से तो ये लगता है कि this is the most bad X-ray. Okay, whole of the right hemithorax is opaque. This is also bad, and this is also bad. But this is the most bad X-ray. But when you reevaluate these X-rays, and when you come to the age of these children, so you see the first X-ray is of a 2-month-old child. And for a 2-month-old child, this is the thymus shadow, which is normal for that child. So that would be fine. This is a normal X-ray. This is how the thymus shadow looks on a X-ray chest in a newborn or in a infant. So this is the X-ray of a 7 months old. Again, the thymus size starts to decreasing with the age. but for 7-month-old child, this much size of the thymus is fine. So there is no problem with that. So you see the X-rays which seem to be absolutely abnormal for us, they were in fact normal. ये last वाला X-ray which we were thinking, okay, this is abnormal, but it's fine. This is not much abnormal, but this is an X-ray of a 16 years old child. So this cannot be a thymus shadow. Okay, if it would have been an X-ray of a 2 months old child, say 5 months of child, then fine. But for 16 years old, so this is a mass. This is a mediastinal mass. It could be anything. It could be a tumor. It could be lymph nodes or anything. Okay, so this is an absolutely abnormal X-ray. So now you have got to know that why we say that this age is important. Okay. Now coming to the orientation. So orientation में दो चीजें होंगी, एक तो right से left होएगा. How do you come to know that right side which is left side? So basically most of the X-rays label होते हैं, जैसे इसमें ये लिखा हुआ है, this is the L. So you can make out this is the left side and this is the right side. But sometimes they are labeled wrongly or sometimes they are not labeled. So how can you make out? So you have to see for few landmarks, like this is the aortic knuckle. So this is present on left side. Then apex of the heart, that would be present on the left side. And then gastric gas bubble shadow. So that will be present on the left side. So all these things, if you see on the left, on the particular side of the X-ray, that means that is the left orientation of the X-ray. So there would be exception to this case when we are dealing with a case of dextrocardia with situs inversus, and you will see everything on the other side. The second orientation is whether it is AP or PA. Okay, so what is the difference between a PA view and AP view? So here you can see when we are taking X-ray in a PA view, the person is standing here, the X-ray films are placed on his chest and the radiations are coming from back. While it's opposite in an AP view, the X-ray film is behind the back of the patient, radiations are coming from the front. Now this is basically what we have learned in physics during our school days. Okay. So this is basically AP view and this is a PA view. Okay, the source of light is from the front. This is heart and this is back. This is detector. So you can see when you have a AP view X-ray. So these are the radiations coming. Heart is towards the source of the light. So the shadow of the heart on the detector would be comparatively bigger. When we are taking a PA view, the heart is a bit away from the source of light. You can compare these two now. So the shadow of the heart on the detector would be small. So this is how you will, this is one of the features which you will come to know further in that how are you going to differentiate between PA and AP views. And that is the reason why we always say when we are commenting about cardiomegaly in a child, increase in heart size in a child. So you have to do a PA view. You cannot rely on AP view because AP view it is supposed to be large. You cannot say whether this is due to the disease process or due to the technical reasons because the radiations are coming from the front and the heart was nearer to the source of light during the radiation exposure. Now, what are the features which differentiate an X-ray to be PA or AP? हम कैसे कह सकते हैं, ठीक है? So this is you have to keep in your mind कि क्या है when there is PA view the radiations are coming from back, okay? और जब AP view है तो front से आ रही हैं. If you keep these things in mind, so you will come to know कि हाँ ठीक है ये features हो सकते हैं. So what will happen in PA view? Scapulas are seen in the periphery of the thorax, okay? While in AP view these are seen over the lung fields. Okay, there is no scapula. This is seen in the periphery. This is seen over the lung fields. Okay, clavicles project over the lung fields. In AP view, they are above the apex of the heart. Okay, so these are tilted clavicles usually in the PA view, straight above the apex of the lung fields in AP view. So ribs, so posterior ribs are coming first in contact in a PA view, so they are visible distinctly. However, in AP view, the anterior ribs are visible distinctly. Okay. So here you can see, as we have discussed, okay, these are scapula far away, and these scapulas are covering the lung fields. So you can see the heart size. Okay. So then, when you see the AP projection image, it is approximately the heart appears large. How we are going to calculate this ratio? We'll be discussing later. So here it is approximately less than 50%. Here it is more than 50%. It is X-ray of the same child. But the reason being, the orientation is AP and TA. And one soft marker, another soft marker. So whenever we are doing a PA view, so that is usually done erect, usually done in the X-ray department. While AP views are usually done in the sick patients who are lying on the bed. Okay, so whenever we are doing an X-ray in a erect position in a child who can stand, so they are usually told to keep their hands upwards. Okay, so if you find hands going upwards on the X-ray, so that would be most probably a PAV. Okay, now coming to the technical quality. So there are three things in the technical quality of the X-ray which we have to see. We have to look for the rotation, whether your film is rotated or not, expansion, and the penetration. So again, we will come to these one by one. So first of all, coming to rotation, how do you come to know that your X-ray film is rotated or not? So this is a very important aspect, because whenever you are giving any findings, any diagnosis on X-ray, first of all, you should make sure that your X-ray film is not rotated, because if it is rotated, then you will not be able to reliably tell about the findings. Okay, and it's a pity, because most of the X-rays which are being done in pediatric age group, they are usually rotated, because the people who are doing these out there, they are probably not well versed with all these things. So ideally it should be a centralized film, not a rotated film. So how do we have to see? So you have to see the both medial ends of the clavicle. So this is the left clavicle, this is the right clavicle. So this is the medial end of the clavicle, and this is the cervical spine, spinous process rather, okay, of the C7, C8 spine. And you have to see whether the distance of the spinous process is same from both the medial ends of the clavicle or not. So if distance is same, that means the film is centralized and not rotated. Agar ye distance different hai, that means the film is rotated. So is X-ray you can see. I don't know how much you will be interpret on your device. The people you are using phones, it would be difficult to interpret. The ones you are using a bigger device, it would be rather easier. So in this X-ray, so this is the right clavicle, okay, and it goes up to here. This is the middle end of right clavicle, okay. This is the left clavicle. This is the middle end of left clavicle, and these are the spinous processes, okay. So what you see, the distance between the spinous process is more on the right spinous process, and middle end of clavicle is more on the right side and lesser on the left side. So what does that imply? That this film is not centered and this is a rotated film. Okay. This is the most important way to see whether your film is rotated or not. There are few other ways which we will be discussing. Like you can see, you can draw two lines corresponding to the vertebral column, and you can see whether they are equidistant at the corresponding points from the lateral chest wall on both sides or not. And then you can also see the this cardiac shadow. Okay, so normally it should be one third should be on the right side and two thirds should be on the left side in a film which is not rotated. So if it is rotated, so it will be again whole of the heart would be on the left side, or more of the heart may be on the right side. Okay, these are all soft markers. The main marker which is helpful to say whether film is rotated or not is the distance of medial ends of clavicle from the spinous processes. Okay, so you can see this X-ray. This is again an X-ray of chest. Here you can see this is a cardiac shadow. You can barely see any heart shadow on the right side, so it seems a rotated film. और आप अगर clavicles को भी देखोगे, so these are the middle ends of the clavicles. And where is the spinous process? It's here. This is the spinous process. Okay. So how much is the distance? Distance on the right side is lesser as compared to the distance on the left side. So these are the two markers which show that this film is rotated. Okay. अगर first को में हम इस X-ray को देखेंगे तो हमें लगता है नहीं, this is fine only, this is not rotated. But when you interpret it carefully, then you will come to know that this is a rotated film. Okay. Okay, the second point in the technical quality is the expansion. So first of all, this is how the ribs are seen on the X-ray chest. Okay, So these are the posterior ribs. The horizontal ones, the one which is curved going downwards, it's the interior rib. Okay. So here you can make out. So this is the posterior rib. This is the posterior rib. This is the interior part of this rib. It's coming like this. So when you have to count the ribs, the horizontal ones, these are posterior ribs. और जो curved हैं, oblique हैं, they are the anterior ribs. Now, how you say that your film is well expanded or not? Well expanded means whether the film was taken in inspiration or in expiration. In adults, it's very easy. You tell them, okay, you hold your breath in inspiration while you are taking X-ray, but in kids, it's just a matter of chance. So you have to say on seeing the X-ray whether the film was taken in inspiration or expiration, and that is very important. I will come to that further. So you have to count the ribs down to the diaphragm. So diaphragm should be intersected with approximately sixth anterior rib or the ninth posterior rib. So it is like fifth to seventh right, sixth anterior rib or eighth to tenth ninth posterior rib. अगर ऐसा हो रहा है तो then we can say that our film is well expanded. If it is lesser than, usually we count the posterior ribs. Okay. If it is less than the eight ribs or nine ribs, posterior ribs, the intersection of diaphragm, then we say our film is not well expanded. It is 11 ribs, more than 10th rib expanded, then we say that our film is hyper expanded. Okay. So what is the point of this expansion? So if the image is acquired in the expiratory phase or with a poor inspiratory effort, the lungs are relatively airless and their density is increased. There is usually increase in the lower zone opacities. Hilahs become more prominent and more bulky. There is usually exaggeration of the heart size, and there is obscuration of the bases of the lungs. So all these are the drawbacks for if you are not taken the film in the full inspiration. So what is the importance of this? We will discuss with this case scenario. This is a 14 months old child with cough and wheezing. Okay, he has come to the emergency with this X-ray, and the person whosoever sees this X-ray is very much worried. Okay, this is a completely white out. This is a cardiomegaly. This is a completely white out. You can hardly see any normal lung tissue in this X-ray. So if you are to act depending upon this X-ray only, then the only option is you do a EBG and document an ARDS and start ventilating the child with mechanical ventilation. But the person who was attending the child, he saw that the child is not that much sick. He's fine. His X-ray looks very bad, but he's not that much sick. So when he counted the ribs, okay, we'll count the ribs. Okay, this is the first, this is the second, this is third, this is fourth, this is fifth, this is sixth. So these are the posterior ribs. So you see the sixth posterior rib is touching the diaphragm. It is between sixth and seventh, which is intersecting the diaphragm. And what it should be between eighth and tenth, or the ninth rib should be intersecting the diaphragm on the right side. So what we can say that this is a hypoexpansion. This is not a well expanded film. This film has been taken in expiration, and because our child is not very sick, so we would like to repeat an X-ray. So immediately an X-ray was repeated for this child, and we could luckily get an inspiratory film and see what we have got. So this is the X-ray of the same child. Okay, so now you can see 1, 2, 3, 4, 5, 6, 7, 8, 9. So expansion is up to the 9 spaces. Done. So you can see this X-ray is absolutely normal. There is nothing abnormal in this child. You can compare. This is the X-ray of the same child at a difference of say 1 hour. Okay, there cannot be anything which has improved the X-rays so markedly. It is only because this film was taken in expiration and lungs were not well expanded. This film was taken in inspiration and lungs were well expanded. So this child could be managed on OPD basis. Contrary to that, what we were thinking of doing here, admitting the child to ICU and ventilating the child. So again, I would reiterate that we are treating patients or children, not the X-rays. So those has to be interpreted in the history and the finding. And you have always to be aware about these technical qualities like rotation and expansion, and will come to further penetration, because these things will change your findings. We will presume that something is wrong when there will not be anything wrong. Okay. The third is penetration. That depends upon the how much radiation the person who is doing the X-ray is giving. That is a controlling factor. So what is a good penetration? When you say penetration is of good quality in an X-ray, so the word is just see. So you should be able to just see the thoracic spine through the heart. Okay. So this is how you will say that this is a well penetrated film. अगर आपको वो आपके vertebrae हैं, they are visible very clearly with the spaces. That means the penetration is small. Okay. If you cannot see any this thoracic spine, only the heart shadow. That means that penetration is low. Second thing is the left hemidiaphragm should be visible to the edge of the spine. Okay, so this is the left hemidiaphragm. You can see this is visible up to the edge of the spine. So these are the two features where we see that the penetration is fine. One is the thoracic spine that should be just visible, and second is diaphragm that should be traced up to the edge of the spine. An underpenetrated film looks diffusely opaque. You know that now opaque means too white and lucent means too black. Okay, the structures behind the heart are obscured and the left lower lobe pathology may be easily missed. However, in an over penetrated film, it looks diffusely lucent. The lungs appear blacker than usual and the vascular markings and lung details are poorly seen. So इस एक्सरे में क्या लगता है first look में? Okay, it's just completely black. This must be bilateral pneumothorax. Okay, and here you can see this is underpenetrated. There must be some pathology. There must be some consolidation or something like that. Okay, the penetration has also to be fine. So what we have seen in technical quality, there are three things. One is rotation, one is expansion, and one is penetration. So if these three things are fine, then you can give your interpretation of the X-ray with the reasonable confidence. But if it is a rotated film, not well expanded, penetration is not fine, then you cannot comment whether the X-ray is having some abnormality or not. Okay. So coming further, these were the basic things which you have to do while describing every X-ray. Okay, technical quality and the basic details. Now we'll come to the systemic approach. What you have to see on the X-ray chest. What are the old structures and what you have to comment upon all these things. How you have to comment upon all these things. So this is a reasonably simple approach. You have to remember A, B, C, D, E, F, G, H, I. Okay. So we'll come to that one by one. So A stands for airway, B for bones and soft tissues, C for cardiac cylinder, D for diaphragms, E for edges of the heart, F for the fields of lungs, H for Hilah, and I for any instruments if you can visualize like any tubes, Riles tube, endotracheal tube, chest tube in the X-ray film. Okay. So whatever the findings are, they should only be interpreted in the view of clinical setting. We have discussed that. Occasionally, there will be an unexpected finding, the incidental finding, which may need to be considered with caution, especially if equivocal or if does not fit the clinical scenario. So again, this is again and again reiteration that you have to see the scenario as a whole, not the X-ray only. So coming to airway, so what you have to see on the airways. Okay. So you have to start your assessment of the every X-ray by looking at the airways. The trachea should be central or slightly to the right. So this is the trachea. Okay. Normally there is slight deviation of trachea to the right. If the trachea is deviated, क्या हो सकता है? या तो film is rotated है, patient is rotated है. अगर it is a centralized film, then there can be some pathology, or it can be deviated. अगर deviated है तो मतलब या तो वो किसी structure से push हो रही है, या something is some disease process is pulling the trachea. Okay. So here you can see there is some soft tissue mass in the chest which has displaced or deviated the trachea to the right side or shifted the trachea to the right side. Most likely this could be a thyroid enlargement. Here you can see the trachea has been pushed to the opposite side. By what? A massive pneumothorax. Here again it has been pushed to the opposite side by a massive pleural effusion. So we will be discussing all these later on, how well for pleural effusion or pneumothorax and all. So we are just discussing here the position of the trachea. How does that matter? Okay. So what are the, if pathology on the right side and the trachea is also shifted to the right side, then it could be because of either collapse or fibrosis. If it is shifted to the opposite side of the pathology, then it could be some mass, or it could be pleural effusion or pneumothorax, like we saw in these two X-rays. So this is an X-ray chest here. What you can see, where is trachea? So this is trachea, okay, and there is one soft tissue mass, okay. So trachea is, this film is not rotated film. Okay. If you see, the clavicles are fine. So the trachea is deviated to the left side, and there is some soft tissue mass, which has led to the deviation of trachea to the opposite side. The second thing is bony structures. After airway, B stands for bones. So what you have to see in the bones, क्या क्या bones visible होंगी आपको, ribs, clavicles, shoulders, sternum, vertebra, shoulder joints. So you can always find an obvious bony abnormality. Usually, what we tend to miss is the fracture of the ribs. So you have to symmetry deformities, fractures, masses, calcifications, or any light lesions. So here you can see. So this is a fractured rib. Okay. So you will be able to make out only if you see carefully. Okay. And this is the same patient with the fractured rib. So what happened? This is air everywhere in the lungs, in the subcutaneous tissues. So this is subcutaneous emphysema. So that is one of the causes, fracture of the ribs leading to pneumothorax, and then further leading to subcutaneous emphysema. That is a common scenario. Now coming to the cardiac solidity, C for cardiac solidity. So what you have to see in the cardiac solidity? So see, these are the basic structures which form the borders of the heart, the outline of the heart. On the left side, we have left ventricle, left atrium. This is the pulmonary artery, and this is the aortic knuckle, as you see. And what is there on right side? We have right atrium and superior vena cava. So these are the main structures which form the cardiac solidity. Okay. Now, how you have to look for the size of the heart, and you have to calculate the CT ratio or the cardiothoracic ratio. You will be asked about it in your exams. Okay, so you have to first take this distance, the maximum distance where the diaphragms meet the chest wall, between the two chest walls. Then you have to draw a line in the middle of the vertebral column, and then you have to take the maximum distance of the heart from that line on both sides, on the right side as well as on the left side. So this is A plus B upon C. This distance plus this distance divided by this distance, that means that counts for cardiothoracic ratio. And adults, it is more than 50% abnormal. In kids, usually we see if it is 60% or more than 60%, we take it as abnormal. But again, I would like to reiterate that whenever you are determining the size of the heart, it should be preferably a PA film and not a AP film. Because in AP film, it is supposed to be large only. Okay, so this is an X-ray again. We have calculated like this only. This is 11 plus 8 divided by 30. So 19 by 30, it comes to more than 60%. So this is this child is having cardiomegaly. So other things apart from cardiomegaly, which you will be able to comment upon by looking at the cardiothoracic ratio, is pericardial effusion. So this is a typical money bag appearance. Then cardiothoracic ratio, I have not calculated here, but it seems to be more than 70%. Okay, now coming to D. D stands for diaphragm. Okay, after cardiac solidity, we come to D for the diaphragm. So what you have to look in diaphragm. So पहली बात तो ये है कि both the hemidiaphragms are not at the same level on the frontal erect inspiratory chest radiographs, but usually within 1 rib intercostal space height of each other. The right one is a bit higher and the left one is a bit lower. Okay. So if the when we have to say that this is abnormal or there is some pathology, if the left hemidiaphragm is higher than the right, okay, again ये वाला higher हो गया, तो then there is something abnormal. या तो इस side में abnormal है, or if there is something which is pulling this diaphragm up, or there is something which is pushing this part of the diaphragm down. Okay, then that is abnormal. Or if right is higher as usual as compared to left, but the difference between those two is more than 3 centimeters, then again that is abnormal. So these are the two scenarios when we will be considering that there is some push or pull on the diaphragm, and this is not normal between right and on the not symmetrical on right and left side. What else you have to see on diaphragm? There are two types of angles. Okay, so one is this is costophrenic angle, and this is cardiophrenic angle. Okay, so you have to look for these angles. So this will be obliterated whenever there will be pericardial effusion, and this will be obliterated whenever there will be some fluid collection in the pericardial cavity, whatsoever it is, whether it is fluid or pus or whatsoever it is. Okay. So again, another diaphragmatic abnormalities apart from these angles and left and right difference, what you can see on this X-ray. Okay, so where is the left diaphragm? It's so high. And what are these? You can see the air-filled spaces. So this is a diaphragm and this is a herniated bowel. So it could be due to, it could be a case of CDH, congenital diaphragmatic hernia. So diaphragm is gone too up. Now another part after diaphragm, E stands for edges of the heart, as we have discussed. So that is also a very important thing, the edges of heart. So whenever you are interpreting an X-ray of the chest, as we have discussed, this is formed by the right atrium and SVC, and this is formed by left ventricle, left atrium, and pulmonary artery and aortic knuckle. So whenever we are seeing a normal X-ray, the edges of the heart should be clearly visible. You should be able to delineate the edges of the heart. Okay, so this is formed by right atrium, and this area is represented by the right middle lobe. This is left atrium and left ventricle, and this area is represented by the left lower lobe. Okay, so this is called as cardiac silhouette sign. Cardiac silhouette, and usually we call it as silhouette sign if it is visible normally, but it is misnomer. It should be called as loss of silhouette sign. Okay, whenever the cardiac silhouette is not visible clearly, as we discussed, the border should be visible clearly. If there is some blunting of the borders with the surrounding tissues, surrounding lung tissues, that means the surrounding lung tissue is not normal. There is something abnormal with the surrounding lung tissue. Okay. So the normal adjacent anatomical structures of differing densities form a crisp silhouette or contour. Okay. This loss of specific contour can help determine the position of the disease process. So here you can see this is the right heart border. Can you see it clearly? No, you cannot see. This is merged with these tissues in the lungs. So which area of the lung was here? As we discussed, this was the right middle lobe. So there is something abnormal in the right middle lobe. So this is not a normal X-ray of the chest. Here again, you can see this area. Can you make out whether the heart border is visible or not? Not at all. It's not visible, even not on the right side. So there is some abnormality in the lung tissue surrounding the heart, in the left upper lobe, and in the right middle lobe. Okay, so we have discussed the edges of the heart. Now coming to F. So F stands for fields of lungs. So what are fields of lungs? So this is the major chunk of the findings or description which you would be doing while presenting the X-ray test. So when you are giving a diagnosis on X-ray test, this will be the area which you will be focusing upon primarily. Okay, so you can divide the lungs, the radiograph of the lungs into 4 zones. Okay, you can divide them into 4 zones. The apical zone is above the clavicles. The upper zone is up to the second rib from the clavicles. Mid zone, second to fourth rib, and the lower zone is fourth rib to the diaphragms. So you can say abnormalities are in this particular area, or you can also tell about the abnormalities according to the uh, anatomy of the lungs. Okay, so this area corresponds to the right upper lobe. This is right middle lobe. This is whole right lower lobe, but usually the right lower lobe pathology will not be visible on the uh, AP or PAV X-ray of the chest, you can see only these areas, but rest of the pathology will be visible only on the lateral view of the X-rays. Okay. So here you can see the lower lobe. You can see most of the part on the uh, lateral X-ray only, because on AP this will be obscured by the upper and the middle lobe. This is the left upper lobe on X-ray. Whole of the left side of the lungs would be visible as the left upper lobe only, and left lobe, lower lobe pathology is usually missed in the AP or PA view. Again, you have to do a little X-ray. So what are the various, we are discussing about the lung field F or the lung field abnormalities right now. So what are the various things which you will be commenting upon the lung field abnormalities are expansion, asymmetry, whether expansion is decreased or increased, or the expansion is symmetric or asymmetric, whether there is an radiolucency. Radiolucency means black. So that will be representative of pneumothorax. Or if there is a radio opacity, radio opacity means white. So what is the differentials of radio opacity? Only three. It is a consolidation or a collapse, or if there is collection of the fluid or effusion. And the fifth abnormality you have to comment upon is the cavity. We will discuss these one by one. So coming to the expansion. In this X-ray, if you count down to the ribs, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 11th rib is almost intersecting the diaphragm. So this is a hyper expanded film. And you can also see that the heart shadow is, this is called as tubular heart, has been compressed. So this is an X-ray of some disease process which has led to the hyperexpansion of the lungs, which could be bronchiolitis in a small child, or it could be any obstructive airway disease like asthma in a bigger child. Yeah? If the expansion is low, up to 6 or 7 spaces, that could be because of some disease where we have hypovolemic lungs, like in cases of the neonates with Hilah membrane disease, there will be the lung volume will be quite less. So coming to the asymmetry, if you see this X-ray, so what you can see, if you count the ribs, this 1, 2, 3, 4, 5, 6, 7, 8, 9, 9 and 10th, and on this side 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you see the 10th rib is just above the diaphragm. So if you compare the density of the two sides, it's a bit blacker on the left side as compared to the right side. So there is unilateral hyperinflation on the left side. Okay. So what can explain this pathology? So there is some compression on the left main bronchus or the branches of the bronchus because of something. Okay, because of something. It could be some external compression like some lymph nodes or muscles of your foreign body, which has led to the air trapping and the hyper expansion of the lungs on the that side. And further, if that is kept untreated, that will ultimately lead to the collapse of the lung on the that side. Okay, so this is the importance of asymmetry of expansion on both the sides. This is a very difficult to interpret meta-diagnosis of foreign body aspiration on the X-rays, but this is the only soft marker which will tell you about the diagnosis of foreign body inhalation in a child if we have a differential expansion of the chest on both the sides. Okay. Now coming to the radiolucency, when you are seeing that they are more black, okay, that will be seen in cases of pneumothorax as we have discussed. Okay, so here you can see, okay, if you compare both sides, you can, beyond this point on lateral side, you barely see any these white shadows of the lungs. So this is an air trapping. And what else you see? This has gone deep. This the right costophrenic angle has gone quite deep. So what are all these signs are called as? So this is a air in the right hemothorax which has displaced the dome of the diaphragm and costophrenic angle downwards. So this is called as deep sulcus sign. So whenever you see such as when you are in doubt in diagnosis of pneumothorax, you should compare on both sides the costophrenic angle. If you can clearly see such a deeply displaced costophrenic angle, then that must be because of pneumothorax, or you will see double diaphragm sign. Okay, so what is this area basically? So this is basically compressed or collapsed lung tissue which has been compressed with the this air in the right hemithorax. So this is a more clear X-ray. Okay, so you can see basically in this X-ray, trachea is going to the opposite side. Okay, again this is a deep sulcus sign. You see where it is, this costophrenic angle, and where this is, and this has been widened and pushed downwards. So this is right hemithorax is black, and the mediastinum or the heart or the cardiac silhouette, is it maintained? It is not maintained. It has been pushed to the opposite side. Okay, so you can see trachea to the opposite side, cardiac silhouette to the opposite side, expansion with radiolucency on the right side. So this is a right-sided pneumothorax. So this is something which happens here. You can see the air collection. The radiolucency is on the medial side as compared to the lateral side. The air is collecting by the sides of the lungs. So this usually happen in small kids when the X-ray is taken in AP position, in lying down position. The air tends to collect anteriorly and medially. So even if you seeing such a X-ray, then that will also qualify for a diagnosis of pneumothorax. But here we cannot. This child is having tube in situ, endotracheal tube in situ. That's why we are not able to see whether this is deviated or not deviated. Okay, so we have discussed usually in infants when this is medial and anterior to the lungs. The fourth is radio opacity. So as we have discussed, what are the differentials of radio opacity? There are only three things. Either it can be consolidation, it can be collapse, or it can be effusion. So you have to differentiate between those three things whenever you see a radio opaque shadow. Okay. So, so what are the key findings on consolidation? So this is a homogeneous opacity obscuring the vessels. And as we have discussed, there will be loss of the cardiac silhouette. Okay, the cardiac margins or the margins of the cardiac silhouette that will be not visible clearly, that will not be demarked like in a normal X-ray. And third is the air bronchogram. That is the most important part. Okay, so whenever you see collapse or consolidation or fluid collection, so everything will be white. So what is the thing which differentiate, most important things that differentiate it into a consolidation is a air bronchogram. So what is the air bronchogram? So whenever there is consolidation, okay, in collapse, the area is collapsed. No air is going into the lungs. Okay. In pleural effusion, again, everything is filled with the fluid. You cannot see if fluid is overlying the air, you will not be see any air. But in consolidation, it's not like that. In consolidation, it's not like that. The whole of the parenchyma has been cut off from the air supply. The air is still going inside the lungs. There is solidification of the lung tissue, alveolar tissue, but still the air is going inside. So you will see, how do you look for air? Air is black. So you will see small linear markings inside this white opacity. Okay, if you can make out. This is not completely white. You can see small these blackish markings inside this white shadow. So that is an air bronchogram. So that is something which differentiate your consolidation from collapse and pleural effusion. Definitely there are some other features also. Okay, we have discussed here they have enlarged this X-ray chest. So you can see, so this is the radio opacity, but it is not completely opaque. There are something white blackish lines within the radio opacity. Okay, so these are the air bronchograms. Again, here you can see, so this is a radio opacity, but it's not completely opaque. You can see the whitish shadows. So this is again a consolidation. Here in both sides, okay, here you can see this is normal side of the lungs. And what you see here, there is a radio opacity. But again, this is not completely radio opaque. If you can see, I can trace. This is 1, this is 2, this is 3, this is 4, this is blackish lines. So air is still present in this mass. So this is, what is this? This is a consolidation. Again, the same X-ray. This is the same thing again. Okay, this is a massive radio opacity. But this is not completely white. You can see the air bronchograms in between. So coming to the collapse, as we have discussed, अगर collapse हो जाएगा तो there will not be any air. जब collapse हो गया तो there will not be any air. So that will be completely white. Okay. So here you can see. So there will be no air bronchogram. So whenever there is collapse, there will be the loss of lung volume on that particular side. So what will happen? Trachea will be shifted to that side. Hilum will be shifted to that side. Or if there is a massive collapse, the cardiac stellate may be shifted to that side. And if there is collapse, there may be compensatory hyperinflation on the other side of the lung. Okay. Or these are some of the soft signs which usually you cannot make out, like elevation of the hemidiaphragm, because there is loss of the lung volume, so there will be elevation of the hemidiaphragm, and there can be crowding of the ribs. Okay, so the most important thing is you find a radio opacity with deviation of trachea to the same side. So that is collapse and nothing else. So why this is not a consolidation? First is trachea should not be shifted to the same side in consolidation. It should be at the normal place only. And there should be air bronchograms if it is a consolidation. So this is a collapse for sure. Here again you can see in this X-ray. So this is a disease process. You will not see isolated findings. You will see many things in collaboration. So here you can see, can you make out the right heart border? No, you cannot make out. This is confluent with the surrounding lung tissue. And this opacification which you see is not completely white. Although this is completely white, if you compare these two, okay, so this is an area which is consolidated. So this is consolidation and this is collapse. You can see trachea is deviated to the same side as we have shown here. Trachea is deviated to the same side. So this tissue is collapsed. So if we would have seen a clear cardiac shadow here, then we would have said, okay, this is collapse only and rest of the lung is normal. But as we cannot make out the cardiac borders, so this is consolidation of the middle lobe and collapse of the upper right lobe. Again, similar, this is a massive, the whole of the right hemithorax is opaque. So this is a whole lung collapse of the right side. So here you can see in such a massive collapse, trachea to shift hoga hi hoga. And along with that, your cardiac, your mediastinum is also shifted to the same side. So cardiac stellate, you can hardly see anything on the left side. So coming to the effusion, what will happen in effusion? Again, this will be a radio opacity, which will be completely white. There won't be any air bronchograms. Okay. So how you have to make about the effusion? So पहली बात तो ये effusion, if it is not loculated effusion, so it will settle down to the lower ends of the pleural cavity. So what you will see, जो आपके costophrenic angles हैं, they will be blunt. They will not be sharp. You will not be able to visualize the costophrenic angles. Okay. If there is significant effusion, there may be blunting of the cardiophrenic angle also. The diaphragmatic contour is partially or completely obliterated depending on the amount of the fluid. Okay, so here you can see you cannot visualize the diaphragm. Okay, usually you have a convex diaphragm. This is a concave sign. Okay, so you can make out fluid within the fissures of the lungs. And usually you have a concave meniscus seen laterally and gently sloping medially. So this is again, you can see the X-ray chest where we are having a radio opacity. Okay. So what can this radio opacity be? It can be consolidation. Yes, it can be consolidation, but it is not, because this is completely white and you are not able to see any air bronchograms in it. So what we are left with either it could be a collapse or it could be a fluid collection. Now, how to differentiate between these two? अगर ये collapse होता तो there would have been a loss of lung volume. This is trachea. This would have been shifted to the same side. Okay, and in collapse you will not see such a well-formed margin of the fluid, the meniscus sign which you say. Okay, so this is pleural effusion. There is shift of trachea to the opposite side. Whole of the hemothorax is half of the hemothorax is opaque, clearly without any bronchograms. Okay, so this is pleural effusion. There is blunting of the these costophrenic angles. Okay. Now coming to the cavity, this is not a very common finding in cardiac age group. So here you can see. So this is a well-defined thing. Okay, so this is a thick wall. They usually say the wall thickness of the wall should be more than 2 to 5 millimeters, and you can see a air fluid level. So this is fluid and this is air. So there is a air fluid level. So that depict a cavity. So this is a disease vessel usually which happens in staphylococcal disorders. Okay, initially they present with pneumatoceles and may turn out to be pneumothorax and lung abscesses. So that will be the scenario of staphylococcal disease. Okay, so this is how you will visualize a cavity. So you can see this is a well circumscribed area. Okay, round area with fluid collection, not completely filled with fluid in the right hemithorax. Okay, so now I'll discuss few of the chest X-rays. So what you see in this X-ray, okay? So this X-ray is probably there in your bag of X-rays which you will be shown in exam. Okay, so what you see on this X-ray, okay? So we will not be discussing those all things of rotation and central. This is not a central plane, okay? You can make out. So this is the middle end of right clavicle. This is the left clavicle, and this is the spinous process. Okay, so this is near and this is too far. So this is a rotated film. So most of the times you will get a rotated film in pediatric age group. They don't do it correctly. If you have a very dedicated X-ray technician, then only you will get a good non-rotated film. Okay, so what is the pathology which is seen in this X-ray? So you see first of all this. This is a horizontal. This is not a diaphragm. You can see the right costophrenic angle which is blunt. So that means there is some collection of the fluid in the pleural cavity. And what else you see? This is opaque. Can you make out radiolucent? Can you make out any white tissue out here in this lung? If you compare both the sides. So this is completely radiolucent. That means there is some air in the pleural cavity. So what does make these two? Fluid in the pleural cavity and air in the pleural cavity, that makes it a hydropneumothorax. So now what is this? So this is not a hard shadow. So what this shadow is, this is basically a collapsed lung which has been pushed by the pneumothorax as well as fluid. So this opacity is a collapsed lung. Okay. Okay. I have explained that. Again, this is a similar X-ray. Here you can also see. So this is radiolucency. This is air in the pleural cavity. You can very well see the costophrenic angle. There is no fluid, so this is a pneumothorax, not hydropneumothorax. So what is this shadow? This fancy shadow. This is the collapsed lung tissue. This is the air which is compressing the lung, and this is the collapsed lung consequent upon mentioned pneumothorax, which is forming this shadow. Okay, so what is this? So here you can see that the whole of the bilateral lungs are radio opaque, but they are not completely radio opaque. You cannot make out the cardiac borders, neither on the left side, neither on the right side. So here you can see this is not completely radio opaque. You can see blackish shadows. So this is bilateral extensive radio opacity with air bronchogram. So both the lungs are involved. So what is the typical term used for such shadows is a miliary shadows. So these are usually seen in tuberculosis, so in the miliary tuberculosis. Okay, so now we have discussed about the fields of the lungs in detail, all the things regarding whether this is lucent, opaque, expansion, asymmetry. Coming to G. G stands for gas under the diaphragm or the gastric bubble. Okay, so this is how the gastric bubble is seen. And what is the importance of it? Nothing. You have to make out right and left, basically right and left orientation you can make out, or in the small kids if it is a pyloric stenosis, so there will be very large gastric bubble. Okay, and what is this? You can see this is the diaphragm, left hemidiaphragm, this is the right hemidiaphragm, and there is radiolucency below the diaphragm. So this is the air under the diaphragm. So what is the pathology in such cases? There is some hollow viscous perforation in the abdominal cavity, which has led to gas under the diaphragm, air under the diaphragm. Okay. Now H stands for Hilah. Again, what are the structures which form the Hilah? The major structures are pulmonary artery and veins. Minor are fat, lymph nodes, and bronchial walls. But most of the times, abnormalities, whenever we get in the hilar tissues, are usually because of the lymph nodes. So, what is the position of the normal hilum? Left hilum is slightly higher than the right hilum. This is opposite to the what we discussed about the diaphragm of the dome of the diaphragm, in which it is opposite, where right one is higher. Only in minority of cases, the right hilus is at the same level. In most of the cases, left is slightly higher. It is usually a concave shape. You won't be visible clearly. Hilum will not be visible clearly. It will convey shape towards the vertebral column. Size is similar on both sides and density is also similar on both sides. Okay, so this is the right hilar point and this is the left hilar point. So you can see. So you cannot make out any significant radio opacity, radiolucency in this area. The density seems to be similar on both the sides. So this is a normal hilar. So now what happens in this X-ray? You can see there is a radio opacity in the right hilar region. So it could be because of enlargement of the lymph node. That is the most common pathology, or it could be any other mediastinal mass which is giving rise to this pathology. You cannot see such any things on the left side. So you have to, when you have to comment about the these hilar shadows, you have to compare both the sides. So here both the sides are involved. Okay, you can see well-defined radio opacities on the left side as well as the right side. So there is bilateral hilar enlargement, which again could be variety of the diseases. It could be because of lymphadenopathy or anything else. So coming to I, the last is ABCDEFGH. I stands for instrument. So what are the basic things which you can visualize on the X-ray chest? Is like the endotracheal tubosity if the child is ventilated or is intubated. If he's being fed with tube, then you can see an Riles tube. Or if you have done an intervention for any pleural effusion or pneumothorax, then you can visualize an intercostal drainage tube or a chest tube inside the chest cavity. Okay. Or in some very sick patient, if we have put in a central venous line from the subclavian, that can be visualized, or even from the femoral, if it has gone up to the junction of IVC and right atrium, that we can visualize. Okay. So here you can see these are the chest chains. This is a smaller chest chain in a small child. This is for pneumothorax. This has been put for the pleural effusion. What is this shadow? This is going up to the stomach. So this is a nasogastric tube or the Riles tube. Okay, now we will have discussed everything which you should know, how you have to explain and XHS, the basic details, then technical details of expansion, rotation, and penetration. Then you have to comment about everything A, B, C, D, E, F, G, H, I. In this sequence, you can use airway, bones, and everything. So that is how completes your X-ray chest interpretation. So we will be discussing few examples. So here you can see what do you visualize in this X-ray. Okay, so what all you can see. So there is a radio opacity. Trachea is going to the right side. There is a radio opacity in this area. There is loss of the cardiac cylinder. In this area is again radio opaque. Now, what are your differentials? You see, this area is whole radio opaque. This area is also radio opaque. So when we discussed about the radio opacities, what are the three things which come to your mind? It could be consolidation, collapse, or effusion. So here you can see your angle is clear. There is no blunting of the angle. Okay, so most likely this cannot be fluid. And this in this radio opacity, can you see any air bronchograms? No, this is completely white. So this is not a consolidation. So we think it could be a collapse. So what are the other things in support of collapse? So trachea is shifted to the same side. अगर ये फ्यूजन होता भी we said कि नहीं this is doubtful, हो सकता है थोड़ा blunt हो costophenic angle, and trachea should have been shifted to the opposite side. So all these features, this contribute this X-rays diagnosis to be a right lower lobe collapse. So what you see in this X-ray, okay, again there is a radio opacity, okay, trachea is slightly deviated to the right side, but this is normal. Normally this is also slightly deviated to the right side. What is cardiac happened to the cardiac stellate? This is not shifted, but this is not clear. Okay, this is merging with the surrounding tissue. Okay, cardiophrenic angle you cannot make out. This is X-ray has been cut in such a way that you cannot make out the costophrenic angle. Okay, but what you see in this radio opacity is this is not completely opaque. So there are blackish air shadows within this radio opacity. So this is the right middle lobe consolidation. So here again in this X-ray, okay, so this is as I have told you, there cannot be always a single pathology. What you see here, the right costophrenic angle is blunt. There is a radio opacity that is clearly looking in our eyes, and there is blunting of the right costophrenic angle. And in upper area, what you see, so this is something which is confluent with the right cardiac border, and this is not completely white. Okay, so what you make out a diagnosis, so this is a consolidation of the right middle and lower lobe and surrounding subpneumonic effusion. Because what is the pathology for pleural effusion? There must be something abnormal in the lungs. Then only will effusion occur. So if it's a massive effusion, say up to here, more than this, then you may not be able to make out any lung pathology. But if it is a small effusion like this, only blunting of the costophrenic angle, then you are expected that there will be something abnormal in the lung tissue also. So this is the consolidation of the right middle lobe along with the pleural effusion on the right side. So this is the fusion and this is the consolidation, because we can see many ear bronchograms here. Again, this is the same X-ray. Uh, Here the hilar margin is prominent. You can see some abnormality in the hilar, and this is the area. This is radio opaque, confluent with the cardiac borders. Cardiac borders are not clearly visible, and this is not completely opaque. You can see air bronchogram. So this is again a consolidation. So here they have compared the major radio opacities. Okay, here you can see we cannot make out trachea. Okay, mediastinum is fine, but this radio opacity, this is well-defined radio opacity, and you cannot make out any air bronchograms. So what it could be? It could be either collapse or it could be effusion. But what are the differentiating features between collapse and effusion? Trachea we cannot make out, mediastinum is not shifted, so we cannot say whether this is effusion or collapse. But effusion is likely to be in the lower parts of the, it is supposed to be in the whole of the lung field or in the predominantly in the lower part of the lung fields, in the lower part of the pleura, because fluid will settle in the lower parts. Yes, so it looks most likely a collapse. Another possibility which could be a loculated pleural effusion. Okay, in that case, it would not be going to the costophrenic angles, but the first possibility in this X-ray would be collapse only. And when you see this X-ray again, this is a radio opacity. Trachea is central only. Here you can very well visualize the trachea and how this radio opacity looks like. There are plenty of air bronchograms. So this is a consolidation, typical consolidation. Here in this X-ray, what you see, so this is a radio opacity. Okay, this is not a complete X-ray, it is cut. So this is a pleural effusion only basically. This is the radio opaque shadow going up to the costophrenic angles. Trachea is going, it should be slightly to the right normally, but it is going slight to the opposite side. So there must be some fluid collection here. Here in this X-ray, what you see is trachea is going to the, trachea is central only. Okay, and this is a radio opacity without any air bronchograms. So again, it could be some loculated pleural effusion or it could be collapse. But when you come to the location, this location is specific for the right upper lobe, and right upper lobe is the most common lobe to be collapsed in any lung pathology. So this again looks like a right upper lobe collapse. Coming to some other book pictures of the X-ray chest, which we'll be discussing. Okay, so what anybody can say, what is this? Okay, so we are not able to interact much. So this is okay. I'll keep on telling you. So this is agon side appearance of the heart. So this is usually seen in which disease? So this is seen in transposition of the great arteries or the TGA. Here you can see what is this? This is like this, this is like this is like this, and this is like. So this is a figure of 8 appearance. So this is characteristic of which disorder? So this is characteristic of TAPVC or total anomalous tunnel venous connection. And this is a typical upturned apex boot-shaped heart. So this is specific for tetralogy of Fallot. So these are the three main X-rays, the book pictures in cardiology, which you will be asked about. Now coming to a few X-rays of the bones. So here what you can see on these X-rays, this is the AP X-ray of the knee joint. Okay, this is a normal, this is abnormal. Okay, so what you see, this is a well-defined metaphysis. Okay, and there is a little, only a little bit space. The space is quite less. Okay, so what you can see here, these margins are irregular. There is widening of this space, and you can say this has formed a sort of concave cup. So these features are characteristic of which disease? Rickets. Okay. So what we are saying, fraying. What is fraying? These are the indistinct margins of the metaphysis. You should know what you are saying. Basically, all जब भी सब लोग बोलते हैं तो हाँ fraying fraying. फिर उनको पूछते हैं what is fraying, then they say कि नहीं something is pointing out or something like that. So what is fraying? Fraying are the indistinct margins of the metaphysis. You can see these are not distinct like this. These are clearly well-defined margins. These are blurred margins. What is splaying? Splaying stands for widening of the metaphyseal ends. अब widening ये वाली widening नहीं है कि वो side by side widening हो रही है. So widening is of this space, this space. So this is the widening. Okay. And cupping, that can you very well make out. Cupping is very easily. The lower end of metaphysis is cupped. Okay. So these are the three features which are specific for rickets. So another disease is scurvy. Okay. So what do you see on scurvy? Scurvy is basically the pathology in rickets and scurvy is the different pathology. What is happening in rickets? The cartilage is normal and there is no mineralization. Okay, but in scurvy the mineralization is normal, but the problem is with the formation of cartilage because vitamin C is ascorbic acid is required for the formation of cartilage. So what you see, you will see many things white, more white, because the mineralization is fine only. So you will see which the pencil thin cortex you can make out in fibula. Okay, that will be more white, pencil thin cortex. You can see this dense zone of provisional calcification, which is called as white line of Frankel. Again, because there is mineralization is fine and the cartilage is not being laid appropriately. Then you see the Wimberger's ring. The epiphyses are radiolucent in the centers and peripheries are sclerotic, and due to normal mineralization they are sclerotic and they are more radio opaque. And again there will be some increased capillary leaks, so there will be elevation of the periosteum with subperiosteal hemorrhages and hematomas that will be formed. Then you will see the scrobitic zone or the tremor field zone. These are the blackish areas beyond the dense zone of provisional calcification. When this the white line of Frankel extend beyond the margins of this metaphysis, then they form the pointed edges. These pointed edges are called as pelican spur. So this is a real life X-ray of a child with scurvy. So again, you can see these are very clear cut. Cortex is very clearly defined. So this is the pencil thin cortex. So you can see this is pelican spur. This is healing scurvy basically. And you don't see on X-rays such type of rounded epiphyses. So these are the Wimberger rings. So other here in the lower ends you can also see. Okay, there it is not visible. Here you can see the white line of Frankel also. This is the white line of Frankel, and you can see here it is pointing from the lateral side of the metaphysis, the pelican spurs. You don't see here the advanced features of scurvy like periosteal hemorrhages and hematomas. If this child is left untreated, then definitely that also will happen, or that will also appear. So this is also an X-ray of bone. This is also a real life case scenario. So what you can see, there are multiple fractures, okay, and they are healing in different stages. This has malunited and healed completely. Here there is only some callus formation. So different fractures, multiple fractures in different stages of healing. So this is a diagnosis is of osteogenesis imperfecta. And you can confirm your diagnosis in small child, in infants, if you do an X-ray of the skull. What you see, the skull bone is like small bone. So this is called as Wormian bone appearance. So that is also typical of osteogenesis imperfecta. Okay, so that is all for the X-rays. Now I'm going to show you 10 or 12 X-rays which are currently lying in the bag, which will be shown to you during the exam. So one is this X-ray. I don't know whether you will be able to appreciate it on the screen. Before your exam, you can make a group of five or six. We can I will keep them in some particular area in 43 or something, and you can at least see those X-rays. And if you have any confusion, you can always talk to me or anybody else in that area who is presently working there in area 43. So this is the one X-ray. So what do you see here? So again, this is a radio opacity. Okay. So क्या क्या हो सकता है? Effusion, collapse, consolidation. Trachea is, where is trachea? Trachea is central. It's not deviated. Okay. What is cardiac silhouette? That is normal. Margins are clearly visible and it has not been shifted. Now the right ko shifted and ये left ko shifted. And this radio opacity is not completely black. You can see small blackish shadows inside the radio opacity. So what it is, all these features, what does make it? Trachea को कोई problem नहीं है, cardiac silhouette को कोई problem नहीं है, radio opacity with air bronchogram. So this is a consolidation of the right upper lobe. Okay. So here, this is a very bad X-ray, extensive X-ray. Here you can see there is involvement of the bilateral lungs. Okay. So here again, you can see there is diffuse homogeneous radio opacity with air bronchograms. Okay. So this is consolidation. This is probably an X-ray of a child with acute respiratory distress syndrome. Only small areas of lungs are aerated. This much on this side and this much on this side. The rest, everything is consolidated. So this is an X-ray of a infant. Here you can see what are the things which you can see. Don't look at the abdomen. We are discussing about the X-ray chest only. So what you can see is, so here is a radio opacity. Okay. What is this? So this child is having an endotracheal tube in situ. This radio opacity is, this is the one, someone who has taken the picture has taken the picture from the opposite side. Okay, this is the right side. This should have been on this side. Okay, that's fine. So this is the right upper lobe area and in an intubated child who is completely radio opaque. So this is nothing else but a collapse of the right upper zone. Okay. So here again, you can see trachea is slightly going to the right, so it's not deviated like anything. And there is a radio opacity with multiple air bronchograms. Again, this is the cardiac silhouette is normal. It's not shifted to the opposite side. It's not shifted to the same side. It's not collapse or effusion. It is consolidation. Oh, so here you can see the X-ray. This is a radio opacity. So this is a mixed picture. Okay. So you cannot see the costophrenic angle that is blunt. So there is something, some fluid is there in the pleural cavity. Intercostal tube has been put in, and you can see this right border of the heart is not clear. This radio opaque area in the right side is not completely radio opaque. It's with air bronchogram. So this is the consolidation of the right middle lobe along with the pleural effusion and a chest tube in situ. So this is extensive radio opacities on both sides. You can see some air in the subcutaneous spaces also. So this is also an evolving subcutaneous emphysema. Okay, you can see air up to these places. So this could not be because of some like lung pathology. It must be because lung pathology will definitely be there, but this picture is suggestive of subcutaneous emphysema. So here you can see the pathology on both the sides. This side is completely radio opaque, and his area is radiolucent. You cannot see any whitish areas or bronchovascular markings in this area. There is a chest tube in situ. This sulcus is deep. There is a deep sulcus sign. Okay, the right costophrenic angle is deep. So this is basically pneumothorax on the right side, or this could be massive effusion on the left side, or this could be collapse. But it seems more likely to be a collapse, whole lung collapse of the left side. Why? Because if it would have been such a large effusion, the mediastinum would have been shifted to the opposite side. Okay, but it's almost mediastinum is not shifted, so it must be some collapse. It we cannot rule out. It can be effusion also. So here you can see this is a radio opaque area. The costophrenic angle is clear. So here you can see a very well defined air fluid level. So this is a consolidation with cavitation in between. Okay, so there is some lung pathology, the consolidation which has been kept on untreated for quite some time, ultimately has led to a cavity formation. Right side of the lung fields are normal. The angles are clear and everything is clear. Left side, sorry. Here again in this X-ray, this is also a similar X-ray. Okay, the pathology, the disease process is evolving. You can see the right costophrenic angle. You cannot visualize that. That is blunt, and there is a radiopacity in the upper area, which is showing here bronchogram. So this is the consolidation. The disease process he has led to the pneumonic effusion. So this is pleural effusion with a consolidation. Okay, so these are the X-rays of chest view X-rays which are lying there. So this is an X-ray of the wrist. This is being shown to every student. Okay, when you are not किसी को तो ये पहले ही दिखा देंगे अगर कोई और नहीं बता रहा because this is the most simple X-ray. But I'm sorry to say, many of the I usually take X-rays during the send-ups. There are many of the students who are not able to explain even if such a small X-ray. When we show these X-ray to them, so this is Rickets. So then I tell them, okay, tell me, how do you say this is Rickets? Then they say this is fraying, splaying, cupping. फिर मैं उनको बोलता हूँ दिखाओ कहाँ पे है कपिंग कहाँ पे फ्रेइंग फिर वो कहीं यहाँ घूमने लग जाते हैं ये यहाँ पे फ्रेइंग है ये कपिंग है so this is glaring into your eyes your abnormality is glaring into your eyes okay so these are the lower ends of radius and ulna you can see these are not indistinct as we discussed now so that is indistinct margins of both the lower ends this is playing and fraying and you can see definite cup formation convex end. So this is you have to show where is the problem basically. So here is the area where you are having problem. So this is a small child again you can see this is a widening of the space. Okay. So there is widening, there is fraying and spraying, there is cupping. So this X-ray is typical of rickets. So everybody should be able to tell about at least this X-ray if not any other X-ray. Okay. So to summarize, this is what we have discussed. पहले identify करना है, then you have to look for the time frame and indication, age and orientation. These are the basic four things. Then very important is the technical quality. What is the rotation है कि नहीं है, expansion है कि नहीं है, well expanded है, inspiratory है, expiratory है, or penetration. These three things are very important. And then you have to look for these features: airway, breathing, cardiac rate, diaphragm, edges of heart, fields of lungs, Hilah, and instrument. And the easier way to remember these is A, B, C, D, E. Okay. So I think that is fine. Anybody wants to ask anything can ask me. So we have 58 students who are attending, and approximately 42 not have not attended. So the 42 which have not attended, you tell them at least you should be able to explain the X-ray of rickets in exam, because that becomes very embarrassing if you are not able to say. Then keep on searching for the findings on metacarpals and phalanges. So the external feel skinny, what we have taught them, nothing. Okay, anybody wants to ask anything, please ask me. You can ask me. You can raise your hands, you can unmute yourself, and you can ask. All of you are unmuted from my side. So we do not have any questions. Anyone? I cannot see anything in the chats either. Okay, so can we finish? Anybody wants to ask